Our presenter for an update on AJCC 8th edition TNM staging is Donna Gress. Ms. Gress is the Cancer Staging and Registry Operations Manager for AJCC and Cancer Programs. She was the technical editor of the AJCC Cancer Staging Manual 8th edition and lead author of the manual's Chapter 1 Principles of Cancer Staging. An active member of NCRA, Ms. Gress is a past president and has served on several committees. She is also faculty on NCRA's CTR Exam Prep Workshop, the CTR Exam Webinar Series, and the Fundamental of Abstracting Workshop. In this presentation, Ms. Gress will discuss questions on using the Cancer Staging Manual 8th edition and review issues such as blanks versus X, neoadjuvant therapy, post-therapy YP staging, and progression using case examples. Please welcome Donna Gress.
Welcome. I'm Donna Gress, and this is the update on AJCC 8th edition TNM staging. Our learning objectives are to solve some common questions from the past and present, dissect new stage data items and future staging changes, and demonstrate some staging issues through examples and analogies. Now, the annual updates. AJCC is changing how it updates and releases content. We're shifting from Cancer Staging Manual to Cancer Staging System. We're moving from editions to versions. This better aligns with the software development and how many users really consume our content. After 40-some years and 8 editions, it was time to modernize. Users want AJCC content in their everyday software products. Medicine is changing more rapidly than a new book every 7 years, and it's critical to provide new staging content to improve patient care. Now, cervix uteri will be the first cancer updated as a version. This will be effective with cancers diagnosed January 1st, 2021. This replaces the 8th edition cervix content from the staging manual. Now, the version 9 cervix uteri release. The electronic tables have already been distributed to the licensed software developers. The electronic version of new content includes tables, notes, illustrations. This will be available for purchase soon by physicians, registrars, and our other users. It will be a standalone product, and final details will be coming in the fall of 2020. Other disease sites will be updated to version 9 in coming years. Updated disease sites will go into effect January 1 following the release. Clarification, blank versus X. I know this is confusion for a lot of people. So X, this is defined by AJCC as cannot be assessed. Only physicians assess patients through exam, imaging, procedures, and surgery. X must only be the physician perspective of the patient's story. If X definition is not met, the only option left for registrars is blank. There is no other choice left for the registrars. There are no other AJCC values left to assign if X and 0 through 4 are not correct. So the registrar would not assign an AJCC category if a definition is not met. You wouldn't do a T2 if that didn't meet the definition of T2. So don't change the rules for X. This is not the same as unknown to the registrar. We are really telling the patient's story through staging. X means the physician has no results or the results cannot be quantified. For clinical staging, this is the story of the patient's diagnosis and workup. So CTX means the physician has no exam or imaging results or the results cannot be quantified. For pathological staging, it's the story for the patient's diagnosis through the surgical treatment. PTX means that the specimen cannot be evaluated, may be fragmentation or destroyed, and there was no clinical information or operative findings that can quantify the T category. So for the registrars, if it doesn't meet that physician X definition, their only option left is blank, and that means the registrar had no access to the physician information on the patient. Other uses for blank. CT blank could also mean that there was no workup for the patient. It was an incidental finding at surgical treatment. And PT blank means the patient didn't have surgical treatment. Now, physicians have asked why They found CTX on M1 breast cancer cases in the NCDB files. They were trying to do a study. Well, CTX would indicate the tumor was identified on imaging, but you can't determine if it was T1, T2, etc. Or there was no assessment of the breast. Maybe the patient refused exam or imaging, or maybe imaging was not necessary because the physician wanted to first start treating the metastasis and didn't do a workup of the breast. Now, I did tell the physicians that CTX could incorrectly mean the registrar didn't have access to the information. This may not represent what the physician knew about the patient, which it really should have. Some registrars use CTX if they can't find the information or they don't ask the physician. So registrars using X versus blank really skews the data for physician researchers, and the registrar X could lead to incorrect conclusions on patient care actually being published in a journal. So you can understand now why it's so important to use this correctly. Now, I'd also like to talk about a clarification on how to use pathology report TNM staging information. So here's a scenario. The PET-CT chest shows a 3 centimeter right upper lobe lung mass, mediastinal fat invasion. Right upper lobe lobectomy and a mediastinal node dissection were done. The operative report notes right upper lobe tumor invades mediastinal fat, and the path report states the tumor invades parietal pleura, PT3PN0. Well, in this case, the operative findings were more extensive than the path report. The surgeon noted the invasion into the mediastinal fat. An invasion into mediastinal fat is T4, and you can actually find this listed on an AJCC table 36.12. So when you're looking at the information from the pathologist in their pathology report, the specimen the pathologist received was only a PT3. It didn't microscopically disprove those operative findings. So the path report provides helpful information, but it is not the job of the pathologist to synthesize all the clinical and operative information. You cannot use the pathologist stage as the patient stage. The patient stage is the responsibility of the managing physician. Remember, pathological stage equals clinical plus operative findings plus path report specimen. So the pathological stage was CT4 plus PT4 plus PT3, which means the final should be PT4. Now, no residual on a path report. Here's another scenario. The patient had a TURB with invasion into lamina propria, and the path report was PT1 and X. Then the patient had a cystectomy with no residual cancer, path report PT0 and X. So the pathologist PT0 is for the specimen, not the patient. Remember, pathological stage is clinical stage plus op findings plus resected specimen path report. So a clinical T1 plus no findings plus PT0, 1 plus 0 plus 0 equals 1. Therefore, the pathological T category is PT1. Now, neoadjuvant must be the initial therapy. So here's another scenario. The patient had a lumpectomy with a node dissection. The path report was staged PT3 and 3A. This was followed by a full course of chemo. Then they proceeded with a total mastectomy, and the path report staged YPT1C and X. Well, the case is not neoadjuvant. Neoadjuvant must be the initial therapy. Initial surgical treatment followed by adjuvant therapy and further resection. This is only clinical and pathological staging, and there is no stage classification after the mastectomy. So it is never both P, initial surgery, and YP, initial neoadjuvant. They're contradictory. So again, when you're looking at the pathologist and their pathology report information, they may not know the treatment plan. They only see the cancer cells were affected by the drugs, so they cannot stage the patient. The path report is just one piece of the pathological staging. This provides helpful information to the managing physician. Only the managing physician knows the full story to stage the patient. Now, the surgeon and pathologist differ on staging. They have different points of view on staging information. The pathologist assigns the TNM to the specimen. usually only has one piece of the staging information. They may include additional information if known, previous biopsies or clinical information, but it's not their responsibility and they may not have that information. The surgeon or managing physician assigns the TNM for the patient. So the surgeon, managing physician, and the pathologist may not always agree. And we actually had reports that registrars were asking a surgeon to get the path report staging changed when it didn't match the surgeon's staging. That's just not appropriate. It's fine when they don't match because, again, they have different points of view. And the surgeon or the managing physician is the one who stages the patient. Remember, pathological stage is clinical stage plus op findings plus the path report. Now, post-therapy YP staging. Neoadjuvant therapy for post-therapy YC and YP staging should meet national treatment guidelines. So systemic therapy, which is chemo, hormone, or immunotherapy, must be provided by dosage and time frame, meeting standard national treatment guidelines to be considered a course of treatment. The drug guidelines have been proven to have treatment effect on the patients when it is followed as it is in those guidelines. Now, providing a drug in any dosage for any length of time does not make it treatment. Just because a drug is on the list identified as being chemo, hormone, immunotherapy does not make it treatment for the cancer patient. So a short course of tamoxifen is not treatment. It's given to see if the cells react to the drug as a surrogate of tumor response. It predicts if it's then given for a standard of 5 to 10 years as treatment after surgery. You can see that's a long period of time, so it's good for them to know if there will be a tumor response. The drugs given for unconventional reasons prior to surgery. Physician experts and national treatment guidelines make it clear these drugs are not given to treat the cancer and do not provide treatment to the patient. Now, there are no pandemic exceptions. Few months is not neoadjuvant even in the pandemic. If cases were actually planned neoadjuvant, they would finish their entire course of systemic therapy. You would not take them to surgery early as soon as the pandemic allowed. So do not confuse bridge therapy cases with true neoadjuvant therapy cases. These cases with this shorter course during the pandemic should be staged as pathological. Now, we do not want to confuse post-therapy staging. We only want to include cases with neoadjuvant therapy meeting those guidelines. Now, pathological staging must be analyzed carefully during this pandemic time frame, understanding if the bridge therapy was actually given and analyzing the effects of that bridge therapy. We will have the ability to analyze this unique data based on the date systemic therapy was started, following the registry rules, and the date surgery was performed, supplemented by a brand new stored data item that will document the pandemic treatment delay. Now, lack of response is not progression. If there's no response to neoadjuvant therapy, this is not considered progression. If a patient does not respond to neoadjuvant therapy, that means the tumor cells continue to divide and grow as they have been since the day the cancer cells first started. This causes the tumor to expand and invade additional tissue and nodes. So you will assign post-therapy stage indicating that further involvement. For example, what was a clinical T3 may now be a post-therapy pathological YPT4, and what was a CN0 may now be a post-therapy pathological YPN2. Now let's talk about the future for post-therapy YC staging. There are 3 types of neoadjuvant therapy patients. We have patients with a good response who go on to have a surgical resection, and they have the YP staging. That is 100% covered in our data because the registrars are currently collecting that. But if a patient has no response to neoadjuvant therapy and their surgery is canceled, that's YC staging, and that is not collected at all right now. That is a missing piece. Also, if the patient has an excellent response, no surgery is needed, That again would be YC staging, and that is not collected. It's a missing piece. So neoadjuvant therapy with no surgery. This is a significant issue causing incomplete data analysis. It's estimated that 20% of neoadjuvant cases have no surgery across all disease sites, and 90% of anal neoadjuvant cases do not have surgery. So you can see what an issue this is. Neoadjuvant therapy is gaining in popularity. Some examples of the sites that are currently getting neoadjuvant are head and neck, esophagus and stomach, rectum, neuroendocrine, soft tissue sarcoma, melanoma, breast, GYN sites, and adrenal. And these are just some examples. So the missing piece of neoadjuvant with surgery canceled is really a problem. It gives a skewed picture of patient outcomes. This could lead to erroneous conclusions about the success of neoadjuvant if we're only recording it in certain patients. This affects many patient populations. So it's critical to capture this data on the missing piece. We cannot keep telling just part of the story. The complete story must be told to evaluate all treatment results. This is a treatment completeness quality issue. Now, post-therapy YC staging. The COC will begin collecting YC staging starting in 2021. Why is this YC staging necessary? Because it shows the patient treatment plan initially included surgery. The treatment plan changed due to either good or poor response, and it shows the exact level of response compared to the clinical stage. So here's some examples showing that level of response. So a patient with no response went from a CT3-CN1 to a YCT4-YCN1. And so researchers can see the exact difference that took place. And for the exceptional response, we see a clinical T3 clinical N1, which is now a YCT0 YCN0. So that exact level by doing the YC staging is so important to researchers. Now, timing is everything. I've been using this graphic that I developed since the 7th edition, so you're all familiar with it. But it's just a good reminder. You can see the two arrows in the middle that show the two different main paths for the treatment, either surgical treatment or neoadjuvant. And then the arrows at the top and at the bottom show where staging either overlaps or where there's a clear break between the information used for staging. So please use this as a good guide. Now, registry cases and their applicable AJCC stage. For patients receiving surgery, they'll have clinical and pathological staging. For patients with neoadjuvant and surgery, they'll have clinical and the post-therapy YP staging. For those that have neoadjuvant with their surgery canceled, they'll have clinical and YC staging. And for patients receiving systemic radiation therapy only, the registry will only record clinical staging. So a registrar never assigns more than 2 AJCC stage classifications. We only ask for the YC when the YP cannot be assigned. This provides an assessment of the response, which is the difference between clinical staging and YC staging. Without YC, you cannot distinguish between the treatment. There are different treatments for cases 3 and 4 on that previous slide. 3 was the neoadjuvant therapy with surgery canceled, and 4 was the systemic radiation therapy only, no surgery planned. But without YC, they look the same in the data. So here's a case scenario. We have pancreatic T2, 4-centimeter tumor with no nodal involvement. The patient received neoadjuvant chemoradiation. The tumor was 3 centimeters now on imaging with no nodal involvement. So they started their planned surgery, their planned pancreatoduodenectomy, but that surgery was aborted when a liver nodule was found on exploration and a biopsy showed metastasis. So the physician did state that the liver mets were probably present at initial staging, but occult, too small for imaging to detect. So what is the correct stage? You'll see 4 choices here. I want you to think about these 4 choices and write down your answer, and the correct answer will be revealed later. So you can see A is a YP stage, B is a YC stage, C is patient has progression, so no staging, and D is a clinical stage. Okay, I hope you all have your answer written down. Now, when YC staging must be used, YC is assigned when the treatment plan is neoadjuvant followed by surgery, but that surgery is canceled. Examples when YC must be used: patient doesn't respond to neoadjuvant, so the surgery is canceled, or patient responds so well, surgery is no longer indicated. The YC staging does include an evaluation by physical exam, imaging, biopsy, and any diagnostic procedures. Now, there's no YC stage group yet. There are no YC stage groups for any disease size yet, but the T, N, and M that registrars document is absolutely critical for advancement of patient care, and this will help to develop stage groups in the future. We need all of the puzzle pieces. I know many of us have been doing puzzles during this shelter in place. So what if a piece is missing? You can't complete the picture. You have this incomplete puzzle with a hole in it. Well, T, N, and M are our puzzle pieces, and it is just absolutely essential that registrars understand the need to document the T, N, and M and not skip that just because they can't do the stage group. Now, here's some additional case scenarios where the surgery was canceled. So we have an excellent response with no residual. There's a rectal clinical T3 node negative treated with neoadjuvant chemoradiation. 6 weeks after the completion of their treatment, no residual tumor on endoscopy. This would be a YCT0, YCN0, CM0. Now we have a case with no response, no change in the primary. We have a breast clinical T3, clinical N2A. They received the neoadjuvant systemic therapy. No response in the breast tumor, but they now have supraclavicular nodal involvement, N3C, and the tumor is inoperable. This would be YCT3, YCN3C, and CM0. Now the third type is no response with more involvement. So we have an esophageal clinical T2 tumor with 2 left gastric nodes. They received radiation. Imaging shows tumor extending into the adventitia with 5 nodes involved. So now this would be YCT3, YCN2, and CM0. So here's the answer to that case scenario. The correct YC post-therapy clinical stage is YCT2, YCN0, PM1. The tumor decreased from 4 centimeters to 3 centimeters, but it remains a T2 category. There's still no nodal involvement for YCN0, and the liver mets were microscopically proven for PM1. Now, if you chose some of the other answers, I want to explain why they weren't correct. The YP staging criteria includes a surgical treatment resection. The surgeon's evaluation exploration prior to beginning the resection identified liver mets, so the surgical resection was not performed. If you thought it might be progression, this is not considered progression. The patient did not respond to neoadjuvant chemoradiation, therefore, the tumor cells continued to divide and grow as they have been since the cancer started. This resulted in tumor cells breaking away and depositing in the liver as mets, and the physician states the liver mets were probably present at initial staging, but occult. And if you thought the clinical stage M category was the correct answer, it wasn't, because in the clinical stage, the M category was not PM1. The mets were not microscopically proven during the diagnostic workup, so that clinical stage was not correct because it included a PM1 when it should have been CM1 or CM0 since it was occult and they hadn't found them yet. So information on questions on AJCC staging. You're familiar with this slide. It's our website. It's a great resource for free webinars, critical clarifications, and staging moments. Remember to submit questions to the Cancer Forum where we can all learn from everyone's questions. So in summary, I hope I've clarified some common questions, when to use blank, when the AJCC definition is not met, blank is the only thing you can use. And pathology reports are only one piece of assigning stage. I hope I've highlighted some of the new staging data items and future changes, the annual updates for version 9, the critical importance of YC, and provide that missing data on neoadjuvant therapy outcomes. And I hope I've demonstrated this through examples and analogies. Thank you very much.
Thanks so much, Donna. That was absolutely fantastic, as always. I just
You're
love
welcome.
everything you do. And we have had a ton of compliments and a ton of questions too. So if you would like to just start in with them, I think we have about 10 minutes for questions. So I'll let you begin.
Thanks so much. So you're right. There's a lot of questions here. I'll get to as many as I can, and those I don't get to, please put them in cancer form, and that way we'll make sure you get an answer. So the one I see here is pathological information includes clinical, which we know I think are tired of hearing me say clinical plus operative findings plus the resected specimen path report equals pathological staging. But they want to know if the YPT includes information from the clinical. Absolutely not, never. If you look at that graphic that I use all the time that shows, the diagnostic workup for clinical staging, and then it goes to two different paths, one to surgical treatment for pathological staging. The other path is neoadjuvant therapy, and you'll see there is absolutely no overlap between clinical staging and the post-therapy staging. So if those arrows don't overlap, you cannot include that information. So that's very important. I also see some questions here about vendors not allowing blanks for certain primaries. I think I'll need more information on that because there are things like lymphoma staging where there is no T, N, or M. It's just strictly the stage group. So in those cases, you do an 88, and those are following the rules in STOR. But there's other cases they absolutely must provide you and let you use that blank, because I really felt like I came up with a good answer for the X versus blank. Registrars can't ever make a choice between using a blank or an X. If the physician states TX or NX, that is what you use. If the physician doesn't state that the physician doesn't know, the registrar doesn't have a choice, because X means the physician doesn't have that information. It does not mean the registrar doesn't have it. So registrars don't get a choice of using an X, because the X means the physician doesn't know. So you have to be able to use it blank. And you saw my example there where physicians using NCDB data are very confused by all the X's that they see because they can't believe that the physicians don't know. So you can see where you're really kind of skewing information by filling in those X's when that's not what the physician said. I have another question here on short course tamoxifen or aromatase inhibitor. If those are really not treatment, it's not treatment for staging. It doesn't mean that you don't record that information in the treatment data item, but you don't use it for staging. It is not post-neoadjuvant therapy staging. I know I've had some questions on, let's see, what was it? The bridge therapy. Bridge therapy is the term that physicians have been using for what's happening during COVID. It's just something that they can do in the meantime while they're waiting to do the actual therapy and the actual treatment plan that they want to provide. So that's kind of the term that I'm hearing the physicians use, that bridge therapy. So that doesn't affect staging, because we don't do exceptions for the pandemic. Doesn't mean you won't record it, but you just won't let it affect the staging.
I do see a question here about what to do about correcting a physician, which unfortunately this person states is very often. How do you gracefully handle this?
Well, I found in all the years that I was in hospitals, a lot of times the best way was to ask those very innocent questions. Can you help me understand this, or I'm trying to understand the treatment plan and then exactly what the staging is going to be, or can you explain to me, I missed the information, or I must not have seen it, of how you got the T3 instead of the T2, and I'm really trying to learn. Who can really argue with that? You're kind of complimenting them because you're asking them to teach you and train you, but it also kind of points out and kind of helps them realize that something quite doesn't seem right.
And I think that is a great way to go. Thank you for that.
And we've all been there, and it's a tough position, but I know I get questions all the time in the cancer forum, can you make a decision? And it's like, no, I can't, particularly if two physicians disagree. I don't have enough access to the information. You really do have to finally get brave and ask them and try to figure it out. I see a lot of questions about progression. The progression is a tough one, but really when you're looking at progression, it's going to be this major explosion of tumor and of the burden. Because if you think about it, cancer is continually growing. Just because we saw it one day on a mammogram or a CT scan doesn't mean the cancer gets scared and freezes and that's it and it never grows again. Those cells are continually dividing and growing and progressing along like they always have been. So a lot of times when the physicians talk about progression, that's what they're referring to. For it to really be progression, it's got to be all of a sudden a huge, out of the ordinary explosion of tumor that can't be described by the normal process of cells dividing and growing and expanding and pushing and moving into other territory. And I know I've talked about that answer with a lot of the physician experts at AJCC. And they agree that that sounds valid, but it's really hard to quantitate it in really better terms.
Excellent. Thank you. Did you want to talk about any of the cases or maybe put any emphasis on any of them that you talked about?
And it's funny, I should have listened to my own lecture again before I did this. I was too busy listening to the other lectures. I would say probably, I know registrars are going to have a lot of trouble with the YC. I know that's new. I am planning to do another lecture at the college. We'll be recording it. It will be free to everyone. I think we're looking at mid-December. And I'm going to actually include some of these cases again, because I think it will be helpful to hear them more than once. And so I will be going over those again, and I think that will be very helpful to everyone. I appreciate the fact that people are sending in questions on those. I think that really solidifies that it's a good choice for me to use some of these exact same scenarios instead of worrying about coming up with new ones, and maybe taking a little more time to discuss them and go over them.
And we appreciate that. And you do things in such a wonderful way that we can't help but say thank you for this. And it's just wonderful. Thank you. I appreciate it. But
you're most welcome. Another good question?
Yeah, and I had it here, but because everyone's saying you did a great job. But here we go. In the case of liver mets of an unknown primary confirmed by a liver biopsy, how should we write the T and the N?
If you really have no information, again, it's going to depend on what the physician is telling you. If they've done scans and the physician doesn't think they can identify the primary site, then that's a whole different situation, because we won't even know what chapter to put it under. So it really is going to depend on what the physician's telling you. Because remember, TX or NX doesn't mean the registrar can't read and figure it out. So I think I need a little more information on that one to really kind of figure it out. I know I did see one question where somebody was asking about the fact that the physician on that one case did talk about the liver mets being occult. That's really not that uncommon. And I saw just a question, I think it was over the weekend on Cancer Forum, where a registrar was very confused that they did a CT scan and there was nothing in the liver. But then just a month later, they did a PET CT and they found it, and they were wondering if that was progression. You have to understand the difference between the different types of imaging. A CT scan is looking at the anatomy. And if the tumor's not big enough, they may not be able to see it yet, even though it's really there. Where on a PET scan, that's looking at cells being metabolically active. That's why most of them, they basically give them the FDG, which is a fancy name for a type of sugar. And we know cancer cells, since they're more active and they're growing and dividing a lot more rapidly than other cells, they take up that sugar much faster because they need the energy in order to divide. So that's why on a PET scan, many times you'll see that metabolic activity and know there's a cancer there well before you'll be able to see it anatomically on a CT scan. So I explained to them, because of that difference, that wasn't a progression. That tumor was there all along. It's just that they weren't using the type of scanning yet where they could find it. Because remember, insurance has some really strict guidelines about what they will pay for and when. So sometimes you have to go through these other tests before you can do that PET scan. So that can make a big difference.
Oh, thank you for that. I think, I know I learned something brand new with that just because of the sugar. But I just wanted to let you know that you have, about a minute left. So if there's anything that you'd like to say or just.
No, I'm seeing a lot more questions coming in really about that hormone therapy during COVID-19. If it is not the full course, according to like the NCCN guidelines, then it is not considered neoadjuvant for staging. And I think there's so many good questions here. I really hate that I can't get to all of them. But I think the takeaway message is really post them to Cancer Forum. They're great questions. Give me a little bit of time to play catch up because there's so many coming in. But I'm hoping this helps. I guarantee you we will be doing that neoadjuvant therapy lecture. Right now it's planned for, I think it's mid-December. That will be a free lecture, and we do record those through the college, so you will be able to watch it. We'll be taking some questions then also, and that will be a full hour lecture. And then I'm also planning on doing a lecture on the new cervix version 9 staging. I think that's planned for February of next year. So hopefully you'll be able to tune in for that, and I'll be able to give you some explanations and some guidance that will really help.
That's great. Thank you so much, Donna. As always, again, like I say, we learned so much. Again, I know there are a lot of questions that we did not get to, but again, if you would please send them to the Cancer Answer Forum, then I believe they will be answered correctly. In fact, I know they will. And
we will do our best.
Yes. And
it's such a pleasure speaking to everyone.
We miss you.
Oh, I know. I want to be in person with everybody so much. Hopefully soon.
Soon. We hope soon. And thank you, everyone. You have done. We do have one question before we wrap up.
Okay.
So just to repeat those dates.
Oh, we're looking, they have not been published yet because we're still like working out the title and all of that, but we're looking at probably mid-December for YC staging. That will be an hour lecture, and I really want to dig into the YC, and I'll use a lot of the same examples I used in this lecture and add to them, and we'll have a little more time to explore them a little more carefully. And then probably around February, we'll be doing the cervix version 9, and those lectures will be free. They'll be through the college's new portal system that they're using, and probably I would expect in the next month we'll be having information going out about them.
Great. Thanks again, and everyone have a wonderful day. This has been a fantastic day. I think that we have all learned so much. Again, Donna, thank you.
Thank you.